Before we dive into today's episode, you're probably wondering, Jordan, who's the sponsor of today's episode? And I am very happy to tell you that I am the sponsor of today's episode. I'm sponsoring my own episode. I own the Science Fitness Inner Circle, which I think is the single greatest fitness app in the entire world. If you want to get stronger, if you want to get more flexible, if you want to improve your cardio, your heart health, if you want to lose fat, build muscle, get stronger, all of it in one app. And the cool thing is you can do all of this in the same workout. You don't need multiple workouts for improving strength and improving mobility and improving this and improving that. You can do everything at the same time without spending hours and hours and hours every single week. I make it as simple and easy as possible for you so you can stay consistent. If you've been following me for a very long time and thinking, oh man, I want to join, I'm not sure if I want to join right now. The link is in the show notes. If you're brand new to listening, probably don't join right now. Maybe give yourself some time to get to know me and my content before you decide to give me your money. But especially for those who've been listening for a while and like you're still struggling with your fitness and nutrition, you want to work out 2 days a week, 3 days a week, 4 days a week, you want help with calorie counting or not calorie counting, if you want to be part of the most amazing and supportive, encouraging community in the world, that's what you get when you join the Science Fitness Inner Circle. Link is in the show notes. Now let's get into the episode. Today, I'm honored to introduce you to Dr. Stephen Campbell. Dr. Campbell is my personal medical provider and doctor through Marek Health, and he's been instrumental in improving my health and blood work. Dr. Campbell is a triple board certified physician in internal medicine, pulmonary disease, and critical care medicine. Dr. Campbell has spent years treating some of the most complex and critically ill patients in the ICU. His background also includes a degree in physics from Duke University, medical training at the University of Kentucky, and his residency and fellowship at The Ohio State University. Today, his work focuses on helping people better understand their health through advanced diagnostics, hormone and metabolic treatments, preventative medicine, and a more personalized approach to care. We're going to discuss what most people misunderstand about their blood work, hormones, metabolism, and long-term health, and how to separate genuinely useful health information from the noise online. Dr. Campbell, welcome to the show.
Thank you.
Man, thank you for being here. Thank you for everything you've done for me.
Yeah.
Thank you. It's been wonderful working with you. It's been eye-opening. It's been it's been a pleasure and really a blessing to have you in my corner. So thank you for being here.
My pleasure. Absolutely. Thank you for those words.
So before we dive in and we get into all the fancy terminology and all the research, I just want everyone to know, and myself included, more about you. So can you tell everyone who you are, where you're from, what your childhood was like, and how you ended up becoming a doctor?
Sure. That's quite a lot rolled into a series of questions, but I'll try.
Yeah.
So I'm from Raleigh, North Carolina. That's where I was born for the first few years of my life, lived there. My father had a job that took him to all different parts of the country, so I moved about every 2 to 3 years.
Okay.
Everyone assumed I was a military brat, but I was not. It was just part of his sort of corporate track that he was on that led us to do that. So I got used to new schools, new friends pretty frequently. I was my mom's only son from her second marriage. So my brother and sister were from her first marriage, and they're both much older than me, 10, 12 years older than me. So more or less grew up like an only child, which, has its pluses and minuses, right? But so yeah, and then I guess I ended up moving around so much that when I was in high school, I got tired of moving around. And so I said, well, you know what? I've heard about these boarding schools. I think I'm going to do that. That way I know that I can finish high school in one spot. So I went to boarding school in New Hampshire. Awesome experience. Had a great time there. Really good friendships. From there, went to college at Duke. Kind of went back to North Carolina, where I was from. I studied physics and math. I was not smart enough to go on in physics. It was really challenging, especially when you get more into the theoretical parts of physics. Quantum relativity was sort of beyond my ability to grasp that, right? I need more concrete things. I love the mechanics, Newtonian laws, and all that kind of stuff. So I knew I wasn't going to be a physicist. Similarly with math, once it got more abstract, I had a really hard time with that. So wasn't really sure what I was going to do after college. My brother had gone into medicine, but he was an orthopedic surgeon, and he really talked negatively about that whole career path.
Oh, really?
Yeah. Just because I think he'd been jaded a little bit by some of the things he had experienced early on.
Yeah.
Hospital politics. But I also thought that I might want to work in the intelligence agencies. And so one of the things that they told me is that, hey, you really need to get more international travel experience to make your resume stronger. And so I thought, okay, sure. So I ended up going to the Philippines for,
No way.
how long was I out there? 3, 4 months, in kind of this remote part in southern Philippines on an island where Duke University had like a global health initiative. And so they had something set up out there with a family that was helping some of the children out there, both in terms of education and also in some other things. One of them was a nurse that was helping with their healthcare. And so, yeah, it was a really good experience. People assumed I was there with Peace Corps. It was not a Peace Corps thing. It was just a kind of its own separate journey. But it was me and another student from Duke that went there right after graduation. And so that was great. And that's kind of where I started reconsidering the whole medical field thing again, being out there and seeing firsthand, that kind of raw delivery of medical care to people that really needed it.
Well, hold on, because
Yeah.
I could talk about intelligence agencies and that type of work.
Oh, yeah.
That could be a whole day for me.
Yeah.
Did you decide to go to the Philippines specifically because if you wanted to go into an intelligence agency, like this is what they were looking for?
That was heavily influencing that decision. Yeah.
Wow. So like, what did you want to do in the intelligence agencies?
I wanted to be involved in counterterrorism, involved in recruiting spies from other countries. This is what the Central Intelligence Agency does. I was reading lots of books on it. I was very intrigued by it. Earlier on in college, I thought I was actually going along more of a military route. I was doing ROTC and things like that. And, was really interested in like special forces and those sorts of career tracks, but had some injuries in college. I tore my ACL and then re-injured it. And so was unable to complete that program. And so that was one of many diversions that led me to looking at other things, including working in intelligence. So, but yeah, I think that experience more kind of, again, redirected me towards, well, maybe medicine's a better track for me. It fits my personality better. I probably would not have been a good spy. I don't think I can deceive people that much. I think there's too much of a desire to be honest. Right.
You have to. Mm-hmm. Yeah.
Yeah. So that was a great experience out there in the Philippines. The only thing that was hard about it, really hard, was that it was so hot out there all the time. And I am much more of a Scandinavian type descent to where I like colder weather.
Okay.
And so sweating every night underneath a mosquito net on a wooden plank was difficult to get used to.
Yeah.
And the natives there, man, they're so like, they just boom, they go right to sleep. And I was always admiring how they could just adapt.
You're just laying in your sweat and you're like, this is terrible.
Yeah, exactly.
So when you were there, you were working to help them with their healthcare?
So I was at a school primarily that the family had sort of set up out there because there's a lot of issues with kids in poverty being able to get an education because everything there is you have to pay for school. It's not free in a lot of cases, even from starting at a very early age. And so there's a lot of barriers to kids getting enough education out there.
Really? Mm-hmm. So there's no public education for kids there?
There is, but again, there's different economic factors that come into play about being able to. So technically it's public, but there's some nuances there.
Interesting.
I don't fully recall all the details, but I just know that there was a lot of barriers to kids.
And were you teaching? Is that what you were doing?
So I was like volunteer teaching like English and helping out there doing that. Yeah. And going on trips with the nurse around the island to do her medical visits.
That's awesome.
Yeah.
That's really, really cool.
Yeah. Yeah. No, it's pretty unreal going back into the jungle basically and seeing these huts these people lived in, very bare bones. But what was funny about it is that sometimes you go back into these communities and it would be huts, right? Like I was saying, but there'd be a karaoke machine in some of the houses. So Filipinos love karaoke.
Really?
Love it. Like it's everywhere there. And, there was some nights where I would go, there'd be like a place to stay that was kind of more like a resort area. They had a pool and sometimes I'd go there to take a day off or so and unwind. And there'd be the karaoke bar would just be going all night, like singing all night long. And so it'd be hard to fall asleep because they just keep going.
That's
going.
so funny.
Yeah. And it's not necessarily the best quality karaoke at all times, but yeah, they love it. The lead singer of Journey is actually Filipino, and that's how they discovered him, was from
No way.
his kind of karaoke.
I did not know that.
Kind of cover band days. Yeah.
Have you ever heard Joe Coy, the stand-up comedian?
I've heard of him, yes.
He's Filipino, and he always does entire acts about his mother, who's Filipino, and like I didn't know if you'd heard him. If you understand Filipino culture, which I do not, but he's still hilarious. I bet you'll enjoy his stuff. It's just a lot about Filipino culture. Moving on, was there anything that happened growing up that influenced you to want to get into medicine? Was there anyone, like, without trying to be overly insensitive or just trying to push. Like I have many friends in who were doctors in medicine because someone in their life was sick, and that's what, or they were sick and they wanted to get into it. Was that how you got into it, or no?
No, I don't think that was really a factor earlier on in my life. There was no like one or multiple influencing factors, like having a relative that got really sick, or being involved in hospital scenarios. Not really. That stuff didn't really actually come until later on, when I was actually already involved in medicine. That I started getting more of the inspiration to do things a certain way and take different paths.
Okay.
Yeah.
Is there anything you don't like or you actively disagree with about the current state of the medical system here?
Well, I guess yes, in a sense, but which domain are we going to go into? Are we going to go into the way that hospitals work, insurance, reimbursements? I mean, there's a lot of different ways.
Rather than me deciding, I'm going to just say in terms of the direct impact that it has on the patients.
Yeah.
Is there anything about what you view, and maybe it's insurance, maybe it's politics within the practices or within the hospitals, but my concern is the people who need help aren't getting the help that they need.
Yeah.
And is there anything that you see as one of the major or most significant contributors to that within our system?
Yeah, I think the answer that comes to my mind right away is just the captured nature from the insurance system, right? So every decision I make when I was in a clinical office was said, well, insurance, they're probably not going to cover this. We're going to have to go through this prior authorization part. We have to do this and that. Well, you don't have the right ICD-10 diagnosis code to meet this. Oh, well, we can't get the right, the CPT code, all these things, this jargon that you get used to dealing with. It dictates so much of what you're actually delivering. And some of that, is justified, right? I think that an insurance company can look at certain interventions and say, hey, you know what? The cost to society to do this is really not justify what you're going to get out of this, right? The change to outcomes. And you can make those arguments, but I think it's so hard because when you have an individual sitting in front of you, and it's some test that you think they'd benefit from, but maybe it's not good for the whole sort of everyone, right? But it's good for this person. There's no way to kind of delineate that thing when you're thinking about national guidelines and protocols and everything like that. So it's really hard. It became really hard for me to exist in that type of a box, to where I was so limited in what I could do. I was thinking about other things to do, but I knew that they weren't feasible to do, right? So that was one of among many frustrations. So that was definitely one that was very prominent as I started to practice when I got out of training. And even within training too, it was the same.
I feel like that gets into a real moral and a real dilemma from the perspective of now you have to you're almost like playing God. Like, well, this isn't going to be good for society. It's like, how do you know this isn't going to be good for, like, you don't know what this person could do, what impact they're going to have on the people in their life. And like, that makes me uncomfortable to even think about that. It's like, well, this isn't good for society as a whole because this person isn't going to get the outcome they could get isn't worth it for society. It's like, who are we to judge that? And I'm sure there are things far beyond my comprehension that go into it, but I would feel uncomfortable in that situation. And then just saying, no, you can't have this because your insurance doesn't cover it.
Mm-hmm.
Are you knowledgeable? Because I'm not super knowledgeable on this. Are you knowledgeable on other healthcare systems globally and what other healthcare systems you think might do better, or maybe things that people look at other healthcare systems and say, well, ours should be like that, but maybe they don't really fully understand it enough? Like, what are your thoughts on other healthcare systems?
Yeah, I would probably be in the same boat as you, where I just don't have enough knowledge about those other healthcare systems. I think you'd really have to experience it firsthand to know how it is. I've certainly heard from people from Canada as an example.
Yeah, same.
Right, as a socialized healthcare system, you have to wait 6 months to get your MRI of your knee. Right,
I've heard the same.
Things along those lines that are I don't sound any better. Right, I agree. There's probably a lot of waste that we do, but I mean, I don't know what a better alternative is.
Yeah.
Maybe a country that has a completely privatized healthcare system and see how that works. I'm sure there's problems with that too.
Of course. Problems with every system.
Yeah.
That makes sense. Okay. So when you're looking at the current landscape of health, and especially in the context of as people age, what are some of the most overlooked risk factors that can significantly impact both lifespan and health span?
Yeah, I think one of the ones that I've noticed more and more lately is the problem of, because I experienced this with my father too, like the whole recognizing cognitive decline earlier on, right? I think we've gotten better across the board about earlier recognition of cardiovascular disease, certain detecting cancer at earlier stages. I think all those are making good progress. But I think in the cognitive realm, I think we're still pretty poor at that, right? Because right now the standard of care is that you go into your primary care doctor, or maybe you've been referred to a neurologist because there's concern about, hey, my executive function, they wouldn't use that language. They'd probably say, I'm not able to do, balance my finances, or I'm forgetting things more often, these sorts of early warning signs. So, okay, we'll give you this test called a MoCA, which is a Montreal Cognitive Assessment Test, right? And that's the test where you've probably seen or heard about where, you draw a clock, you label the clock, and they say, okay, it's 11:10, so draw 11:10 on the clock. And then they say 5 words in the beginning of the test, and at the end of the test, they ask you to recall those 5 words. And so that type of test, it's a scoring system to where, 26 to 30 is considered normal. And then there's a in between is like mild cognitive impairment, and then really low scores are dementia. The trouble is that if you're only the first differentiator between normal and mild cognitive impairment, even though it's mild cognitive impairment, there's nothing mild about it. If you have that, you're already significantly impaired. Your executive function has deteriorated. And so, again, it's just an example of we're catching things too late, right? You should have been probably intervening 20, 30 years before, looking at all the different risk factors that could have lowered this person's risk of progressing to even like the mild, even though it shouldn't be called mild because it's not.
So when you're saying mild, like it's under 26, maybe it's 25 or 24 for
Yeah, I don't remember the exact numbers. Something like 16 to 25 is mild.
But by that point, you've already noticed substantial issues in your quality of life.
Yes, absolutely.
When it comes to brain health and cognitive decline, do we know how much of it is genetic and how much is actually in our control?
Yeah, so there's been some good research done on that fairly recently. This is that paper that I think we went back and forth on some emails. Maybe, I don't know if you were CC'd on those, but it was the Lancet Commission. Are you familiar with Lancet Journal?
Yes, of course.
Yeah, so Lancet is like, I tell people, it's the UK's equivalent of the New England Journal, so very prestigious, well-known journal. So if you get published in there, it's going to be high quality, very sort of practice-changing type knowledge. And so their commission looked at, hey, when it comes to dementia, cognitive decline, what are the things we can do to prevent this from happening in the first place? And so they found that about 45% of cases could be completely prevented if we address these 14 risk factors that they found. And a lot of them are probably pretty obvious that you could just name without even having to look at the report, right? So metabolic factors, being overweight, having diabetes, high blood pressure. Some of the other things are probably less obvious, I would say, right? Things like air pollution, you wouldn't think about that, but that could be a big factor. Yep. So air pollution, vision loss, hearing loss are also really big. And then one that's oftentimes ignored, but super important too, is the social isolation, right? So we know that has a big connection to risk of dementia. And that one rings a personal note for me because I think that's where my dad did things wrong, right? Growing up with my dad, I think that he was so good at doing everything else right. He got the executive physicals every year, so cardiac stress testing, blood pressure, cholesterol, all that was on point, had a very healthy diet. He would subscribe to Men's Health and Men's Fitness magazines and was doing all of those things that were in there. Even though those magazines talked about better sex and better abs, they never mentioned how to have better social and deeper connections, right? They never mentioned that. And I think that if they had mentioned that in the 90s, I think things maybe they would have been very different. Maybe would have put more emphasis on that. But he just didn't. He was completely unaware of that. And I think that's what I noticed most when I think back growing up with him is that he worked very hard. He exercised every day, right? He'd wake up early, weight training, cardio, everything, but never did trips with friends, never really had any deeper connections. The conversations with me were very, I don't want this to sound like I had a great dad, right? A great upbringing, but conversations with me were always very sort of kept to, how's practice? What's coming up, next week? What are you doing?
Surface level.
Right.
Yeah.
Exactly. Never ask about, hey, what's really going on with you? Like when his dad died, it was kind of like just a very quick, oh yeah, he was in the hospital for pneumonia and he died. And that was kind of it. Like nothing about how it was affecting him so I just think that his lack of sort of tapping into that part of his brain, in my opinion, is probably what led to substantial cognitive decline because I think he did everything else right.
Yeah.
But
do you know if it was also in his genetics? Like, did his dad have that, or was
no, I don't think his case was driven by genetics that much.
Okay.
No family history of that.
Okay.
Yeah, not to my knowledge. Now, granted, I have not seen him any data like a whole genome assessment on him. But I suspect that no, we wouldn't find any of the big genes in there. I don't know how much you want to go into the genetics of dementia, right?
Yeah,
but
sure.
I think so that other part of it, sure. So 45% are these modifiable risk factors, and another big chunk of it is some of the genetics,
right?
But I think there's two kind of camps of genetics. There's kind of the deterministic genes, to where if you have these genes, then you're almost 100% going to get dementia.
Got
right?
it. Yep.
So those are like your presenilin 1 and 2 genes, and then your amyloid precursor protein genes. So that's why kids with Down syndrome, they have trisomy 21. So they have an extra copy of that amyloid precursor protein. That's why so many kids or adults with Down syndrome end up with Alzheimer's disease because of that genetic.
That makes
so
sense.
It's very deterministic for those, but that's less than 1% of all cases.
Oh, wow. Okay.
So they're rare. The other part of it is the risk genes. So not deterministic, but can put you at substantial risk, right? So that's your ApoE4 is the most well-known one, right? And so that one is boils down to essentially a defect in cholesterol transport in the brain. So you can't clear amyloid as effectively as you otherwise would be able to. So 2 copies of that gene, like 10 to 12-fold the risk of getting dementia. So pretty substantial, right?
Yeah.
But not deterministic. So it's a lot of people would say, well, you shouldn't test it because we can't do anything about it. We can't change your genetics, but you can change all the other modifiable risk factors.
Yes.
You can do things to
Yes.
mitigate some of the downstream consequences of that, right? And there are some interesting interventions out there that are being studied and things that you can do to ameliorate a lot of those effects of having that genetic mutation. So again, I think it's important to know that. I think genetics is a big piece of sort of understanding somebody's risk, right? In addition to knowing how they stand with all those other modifiable risk factors that we can change.
The social isolation one is, for me, among the most important for a lot of the same reasons that you said, especially because I feel like it's under-discussed. And I think it's more discussed now than it was, at least when I was a kid, but it's still very much underappreciated when you go into the fitness or the health realm on social media. It's just, it's still like, now it's get big glutes, and I don't know, it's still get shredded and be lean all the time and calorie deficit, and that's what people talk about. But now more than ever, I think, especially post COVID, people are isolated.
Yeah, it's getting worse with all the all of our work. How much of it is now virtual and Zoom calls?
Yes,
Zoom calls are not a replacement for this type of interaction. It's completely different. It's better than audio calls, but still you're missing a big chunk of.
It's one of the reasons why I like the in-person podcast, because, and I don't know, like you're in and out today, but like many people who will come on the podcast, they'll come stay with me for a day or 2 days. We'll hang out. We get this connection. My kids see it. My wife is involved in it, and then I have a personal connection with it as well. Like there are people in my family with grandparents, parents, aunts, uncles with dementia. And it's, I see a very clear relationship between those who maintain in-person relationships with their family, friends, and community versus those who isolate themselves. And it's just, the difference is stark. It is obvious. And so it's one thing I really try and talk about a lot on social media is like, get out. A lot of the fitness coaches, for example, they hate on group fitness classes. They're like, just do like this strength program. I'm like, listen, that's great. The strength program is great, but what if you could do a couple of these classes a week and forget the progressive overload, forget like the optimization of this, and just think about it from the perspective of you're going to go be with other people. Maybe you'll go get lunch with them after and have these, like, I feel like we really don't emphasize this community enough, and these social networks and these interactions in person with real people enough. And I actually think it's to a massive detriment leading to cognitive decline.
Yeah. Well, I could use that as a segue into some interesting data on which type of exercise is the best for longevity.
I would love that.
Right? Have you heard about the Copenhagen study
Yes,
they did there?
but please talk about it. Yes.
So it was a 2018 study that they did in Denmark to a huge database where they're essentially saying what form of exercise has the best outcomes on longevity, who's living longer because of, or which associated exercise activity has best longevity outcomes, right? And by far and away, it was racket sports came on top.
Yeah.
Right. Tennis and badminton were way up there. And then all the way at the bottom were like going to the gym, working out alone. Right. So, and that's so much of what I think people think is like the best thing, right? I'm going to put on my noise canceling headphones. I'm going to go to the gym, hit my sets, and I'm really doing everything I can. Right.
Yeah.
But now, granted, there's probably some confounders there with
of course.
that, right? So the people that play tennis are probably also more likely to be outdoors more, you know, more higher socioeconomic status, right?
Of course.
But I think the signal is pretty strong that you say there's something here that's probably tied to the fact that tennis is a social sport. When you're playing it, you're interacting with people. So I think there's a lot of things that we can take from that and kind of try and incorporate into our own lives. I know that I try to do that myself. It's hard. You know, I think that I'd much rather just go to my basement and, you know, work at it and be done and not have to have an extra layer of things that I'm doing. But I recognize it's important. And I feel better when I do things like that too.
Yeah.
When I go out and play basketball with a group, I definitely can say, okay, yeah, this is fulfilling a different part of me that wasn't met with just bench pressing in my basement, you know?
You know, when I'm looking at whether it's any racket sport, tennis, racquetball, whatever, or even something like basketball, we could get into the actual physical benefits of it as well, which I think, you know, balance is a major part of it. Change of direction. There are significant plyometrics. These are all things that are fully encompassed in that. I think the main thing that's missing from tennis is just the strength component, the progressive overload. But you get cardio, you get plyometrics, you get speed, you get you get everything except the progressive overload. And you could get the same thing with basketball. You could get the same thing with any of these soccer, whatever, any of these like group sports. You could get so much of this in addition to that group benefit. You know what else? It's funny. A few years ago, I took a Zumba class and I made a whole YouTube video about it. And I was like, dude, the cardio is great. There's significant plyometrics. There's change of direction. And then the community. Yeah. Dude, everyone was having fun and laughing. They invited me out to dinner after. It was just like, I really feel like the current optimization strength world misses the boat on the other benefits of various types of exercise. Yeah. It's one of the reasons why I love jujitsu. And at this point I do it not for exercise, but I love the group. I love the community. I love interacting with people. My co-coach in the inner circle, her name is Susan. She's 65 and she does jujitsu several times a week, and she's not doing it because she wants to kick someone's ass, even though that's a benefit. She's doing it especially for the cognitive benefits of you're learning this new skill. It's essentially like human chess, and then the community that comes with it. So I feel like we've really focused so much just on one aspect of health in terms of like muscle or bone, and we really miss out on so many other things like brain health and community.
Yeah.
In terms of interventions for cognition, for preventing dementia, Alzheimer's, whether it's, I want to discuss both from like a supplemental perspective as well as lifestyle. Are there any things that you recommend for people outside of doing group exercise or group community stuff? Are there things that you recommend?
Yeah, I think we've hit on a lot of them already. I think those modifiable risk factors we were talking about in the beginning, you know, and also going in a little bit more depth in those, like, right? So blood pressure is an easy one, right? People say, oh yeah, I'm good in blood pressure, but how many people actually take it correctly?
Yeah.
Right.
Yeah.
They go to, you know, we get these physical forms where somebody goes to an urgent care office. They're probably maybe doing an automated cuff that who knows when that thing's been calibrated
on their wrist or something.
Right. Maybe they just walked in, they're stressed out from the day. They had some coffee, a lot of caffeine. Like these numbers are all over the place. They're not really reliable. Not to mention the fact that that's brachial blood pressure, kind of a peripheral measurement, right? More accurate is actually a central blood pressure, which tells you the pressure at the heart, which is what you care about. That's really the strain that you're looking to assess. And there are ways of doing that, of measuring central blood pressure, but they're just not widely available. I think we sent you one of the cuffs.
Yeah, I have it right here.
Right, so that can measure central blood pressure. So a little bit better, and all the data shows that it's a far more accurate assessment of risk, to knowing that number and controlling it, and knowing your arterial stiffness, right? So how elastic your arteries are, which is another big risk factor. So yeah, there's some nuances in some of the things that may sound kind of easier on the surface, but you really have to kind of, I think, dive deeper there and make sure that you're actually addressing the risk factor. Sleep is another one. People say, yeah, I sleep fine. I'm good there, right? But how many people have really had any type of true evaluation for their sleep? Right? Have they had a home sleep study? I think there's some things that are really hard to detect unless you get a sleep study that you may not know about, right? One of the examples that's emerging is this whole notion of REM-related sleep disorder, where normally during REM sleep, your body's paralyzed. But some cases, you actually can have spontaneous movements and acting out your dreams during REM sleep.
Okay.
And that's pathologic. That's actually tied to something called Lewy body dementia, which is you have this abnormal protein in the brain that leads to cognitive decline eventually over time. But this REM-related sleep disorder can be kind of an early precursor warning sign of it.
Interesting.
That you're never going to know about unless you had a sleep study.
Right.
So, yeah, I think it's really making sure that you're covering those things in adequate depth to make sure that, hey, we're doing everything we can here to, prevent some of this. In terms of treatments, I think that the supplement world is filled with things that are, hopefuls, right? Lion's mane, right? So increase brain-derived neurotrophic factor, which is also increased by exercise and many other natural things that you do. But that's one that gets, so sometimes I think it's worthwhile looking into some of those. It's just kind of that extra maybe 3 to 5% of benefit that maybe you can gain. Same thing with peptides. I think a lot of people come and say, what about Selenk and Cmax, these nootropic peptides that can help my brain function better, make new neuronal connections? I'm like, well, maybe. I think the evidence is pretty early there.
Yeah.
I don't think they're going to hurt anything or cause any harm. But I never think you should look at that as like the foundational mainstay of what you're doing to stave off cognitive decline, improve cognition, right? I think the other things are far more important. But I don't know if you want to get into like the newer treatments there are for Alzheimer's once you develop it. They're really not good at this point.
Yeah.
There's still a lot of problems with them. Aducanumab was kind of this initial Alzheimer's drug that's an anti-amyloid antibody. So I would say that Alzheimer's probably isn't fully understood like a lot of disease states, but we know that amyloid pathology has a role in it, right? These amyloid plaques that form in the brain. And so the notion was, okay, we design an antibody that gets rid of these plaques and we can reverse cure Alzheimer's. Well, it doesn't work like that at all. Of course, we're oversimplifying things like we tend to do. And that drug also causes a lot of complications. It causes bleeding in the brain in a lot of cases. And so there is a newer generation of similar type of drugs. Lecanemab is one of the newer ones that's out there. It's like a $25,000 a year therapy. In the clinical trials, you may slow progression of Alzheimer's a little bit, but you're not reversing anything, right? It's not curing the disease. So like a lot of disease states, it's best to intervene earlier on before you get to that point. Because what we have once you get there is really not good.
Yeah.
So
let me ask you, what are your thoughts on sauna?
I think that we can take a lot of hints and knowledge from the Scandinavian population, right? I think that it's such an ingrained part of their culture. My sister lived in Finland for a while.
Oh, cool.
And all the houses, most of the houses there, they have a sauna in their home. It's part of their daily ritual routine. And subsequently, we think a lot of their longevity is from all of that practice, right? Maybe it's also some of their contrast therapy they do where they're doing cold plunges and sauna and kind of alternating. But yeah, I think that there's good evidence to support sauna use as another kind of tool, sort of exercise mimetic almost in some cases. But yeah, I think it's a great thing to implement if you have access to one.
Yeah, I'm highly biased just because I love heat and I love the sauna. And then, anytime I see research saying, oh, this is good for you, I'm like, yeah, that's my bias.
Yeah, confirmation bias.
Yeah, exactly. Yes. Yeah, I'm like, all right. But like, I have seen research supporting various benefits, whether it's cardiovascular, whether it's the heat shock proteins, any of these things. I've just always been, I'm not an expert on it. So I am curious as to whether you think there's legitimate benefit from either cardiovascular and or from a cognitive perspective.
Yeah, no, I think mechanistically it's plausible, right? I think that some of the observational studies are definitely encouraging. Are you ever going to get like a true randomized controlled placebo trial? No, you can't do that with sauna because when you're in a sauna, you can't fake that. You can fake a knee surgery, but you can't fake being in the sauna. So, but yeah, again, it's one of those things. It's hard to find an argument to not do it.
Yeah. Do you do it?
Yeah. So I've got a combination kind of red light, infrared sauna.
Okay. And how often do you do it?
3 to 4 times a week, I'd say.
And do you have like a routine that you follow, like for a certain duration, heat, anything?
No, I'm pretty inconsistent with that. I probably could be better, right? I mean, probably do 15 minutes and kind of be. Also, the one that I have, it doesn't quite get hot enough.
Okay.
So it's got incandescent red bulbs, and so it's not as pure as some of the LED panels. So you're getting a little bit more of a broader spectrum of wavelength. Not exactly that, whatever the 680 nanometer. I can't remember the exact number of it. It was red light that's beneficial. But somewhere close to that, I'm getting some. It's not getting to be whatever the studies in the Scandinavian studies showed as a temperature. I don't remember exactly what it was. It was hot.
Yeah, it's
like real hot.
Over 200, I think.
Yeah. So it's cooking. So I don't get that hot. So I guess I'm extrapolating that I'm probably getting some of the benefit, but not all of the benefit there.
Maximizing it.
Right.
Yeah.
I'm not optimizing it, as we would say.
Yeah, exactly. Yeah.
Yeah. But I enjoy it. I think sweating is super important. I think we should probably do it more. Right. All from not just from the heavy metal detoxification standpoint, but from the cardiovascular benefits that you mentioned, improved blood pressure and things like that. So yeah, I should be better about that for sure. But yeah, I certainly try to maintain some consistency with that practice. I'm just not.
You got 4 kids and wife. It's a little bit difficult.
Yeah. Yeah.
And it's at your house.
Yes. It's kind of set up in our bathroom. So like a shower and then this little tent infrared sauna thing is there.
Now, I've talked shit about red light therapy. Do you actually find benefit with it? Because I'm not really well versed on the literature, but like if you say that there's benefit, I'm definitely open to hearing more about that. Yeah.
Again, I think you can find clinical studies that show there is some benefit there. They've actually used in some pretty cool protocols, like with so onychomycosis is a fungal toenail infection.
Okay.
Right? And they found that combining topical methylene blue with photobiomodulation, that big long fancy word just means red light therapy, on top of that was actually really curative for that condition, which is a really difficult condition to treat. Oftentimes you're taking an antifungal for months to get rid of that toenail fungus. So there's some cool applications of it there. I think that, there's a lot of arguments about how deep does that infrared light actually penetrate? Is it getting deep enough to affect the cells that we care about? Or is it just affecting skin cells primarily, epidermal, dermal layer type things? So, I think from a physics perspective, it makes total sense because we know that there's chromophores that respond to different wavelengths of light. And so we know that wavelength, again, I apologize if I don't get the exact nanometer correct,
okay.
But that particular wavelength stimulates these chromophores to improve mitochondrial function. So your energy production improves through that. So there is real science there. And again, you can find some clinical evidence that has been beneficial. I looked into this a while back and I came away saying, yes, this is legitimate. I think there is some good roles for it here. So
I know I've just seen some, those red light masks.
Yes.
I've seen some horror stories of people like they get one off Amazon or something and it fucking burns their face.
Yeah.
Seen some really, so I'm just like, nah.
Well, there's a dose response curve, right?
Yeah.
So like any treatment, there's a sweet spot to where it's not too little, not too much.
Yeah.
Red light is the same way. You can actually overstimulate those chromophores and cause problems. So
interesting. Okay.
You have to be careful about that. You have to know sort of the power, and this is again all this physics stuff. How much joules you're getting and per how many minutes you're in front of it, and all these things matter in terms of that. And so. Yeah, when I had looked into it a while back, I remember I was trying to figure out, okay, so if I have this panel and I set 2 of them up side by side and I lay like this and I rotate every 5 minutes, I'm getting the exact amount of joules that I need to get for right in the middle of this curve, this dose response curve. So I had all that figured out at one point, but I've since forgotten about it.
Yeah.
Don't worry about it. It's too much in the weeds.
I want to talk about my use of tirzepatide.
Okay.
And GLP-1s, and I've been very open about it, and when I first started talking about it, I got a lot of hate from various people in the fitness industry.
Yeah.
And that was almost 2 years ago now. And over time, I've had a number of those people reach back out and say, I'm sorry, I was wrong, which is nice, like that they did that. I feel like we're starting to see the tide shift a little bit now, as I think a lot of people are realizing, number one, a lot of people use them and they've just been not telling anyone because they've been scared of judgment, shamed about it. And as more and more research comes out, people are like, oh, this might actually be beneficial for me. And it's not just a weight loss drug. It's not just a diabetes drug. There are many potential benefits of it. So I would just love to hear your thoughts on GLPs as a whole. And then if you want to discuss like my personal use of it, we could do that as well too.
Yeah. Well, I think just like you can make a lot of analogies here. Just like testosterone is not just a low libido agent, right? Tirzepatide is not just a diabetes agent. It has much more far-reaching implications of that. I mean, there's so many new studies that have come out with all the different positive correlations. I really haven't seen much in the way of negative impacts that they're having on the physiology, right? Everything from cardiovascular risk to, risk of dementia, cognitive decline, even microbiome effects of these GLPs have been shown to be positive in terms of the way that it's shifting the gut microbiome. So, yeah, and I've seen that clinically too. I think that pretty much every patient that gets started on them has a really good response, right? Of course, there's probably that subset that either has just the slowed gastric motility is too much for them. They get too nauseous. There's more of a problem with semaglutide now than tirzepatide.
Yeah.
Tirzepatide is far better tolerated.
Yeah.
It's not as strong of an agonist on that GLP. So I think that's why it's better tolerated. I'm not 100% sure on that, but that's what I recall reading about. But with tirzepatide, yeah, it seems to be even at the lower dosages, especially, is where it really we get results without running into some of the issues with. Yeah. I've had some people that will crank up the dose without telling me, and they'll come back and say, "This is great. I haven't eaten in 3 weeks." And I'm like, "That's actually not the goal. Please don't do that." But yeah, so as long as there's not sort of that type of abuse with it, I think as a tool, they're very valuable for a myriad of different things that can go on, right? Everything from insulin resistance, metabolic health, to people also describe this natural, not natural, right? But it comes with an anti-inflammatory benefit to it that I don't fully understand, but I've had many people with sort of inflammatory joint issues come back to me and say that those feel better on these GLPs. So, and I think with the, a lot of people worry about the GI side effects too, but I see less and less of those with tirzepatide than I do with semaglutide. Much less nausea, much less of these sort of constipation, diarrhea type issues. Tends to be and if they do happen, they tend to be very transient.
Yeah, like soon after the injection, and then after a day or two, they're gone.
Right.
Yeah.
Yeah. Yeah. So again, I think the preponderance of data is weighted towards more benefits than anything right now. I'm trying to think if there's instances where I would say it's a bad. I think, yeah. I mean, if someone has an eating disorder, right? I'm probably not going to do that because that can probably fuel that fire a little bit too much. They might be tempted to kind of go
specifically like anorexia, you mean?
Right.
But binge eating disorder might actually be beneficial.
True.
Yeah.
Yes. Yeah. Exactly.
Okay.
So those kind of situations that are rare. But yeah, again, I think it's a lot of times it's actually overcoming that bias that's already out there about them. I think a lot of people say, "Oh, that's that cheating weight loss drug that people go on."
Yeah.
Right? That's kind of the branding, not the branding, but the aura around
the
these
cultural.
things, right?
Yeah.
Exactly. So I think a lot of discussions tend to be just kind of circumnavigating that and kind of coming to a better understanding of why we want to do this, what they can potentially help with, and how it fits into everything else that you're doing.
I don't know if you, I don't expect you to know my numbers off the top of your head, but one of the things that was really, it took me by surprise was looking at my inflammatory markers after starting tirzepatide. Could you talk about which blood work we're looking at when we're looking at inflammation and why might my inflammation have gone down after starting tirzepatide?
Yeah. Probably the one of the mainstays of looking at systemic inflammation is a CRP. So and it's not just it's actually the high sensitivity C-reactive protein. So a classic CRP assay will only detect like 3 and above, but a high sensitivity one will detect, everything from 0.01 or whatever up pretty high, much higher ranges. So the high sensitivity CRP is sort of a screening test to look for, hey, is the body giving any evidence of inflammation? It doesn't tell you what's causing it. It's just sort of a red flag that comes up. And I think that sometimes we spend a lot of time thinking about what could be causing this. I think a lot of times it's obvious, right? So you just had a surgery where someone had like a laparoscopy. Well, of course you're going to be inflamed after that, right? The body's healing everything else. Or, you're just recovering from an illness. Very expected signs. It's the transient rises in CRP are not concerning. It's more the chronic elevations. That's what we call chronic inflammation. That's the problem. That's where all the risk comes from. And so, how does tirzepatide address that? Probably through a variety of mechanisms, probably through, we mentioned the gut microbiome. Maybe there's something there that's causing some degree of inflammation systemically. So you're kind of helping correct that with these, right? maybe there's something with visceral fat, that we're reducing the visceral fat, therefore we're having less of those inflammatory signals from the visceral fat. So those are just a couple things that come right to my mind, and probably other things that I don't fully understand yet that are also going on.
What about like blood sugar regulation?
Oh yeah.
Yeah.
Yeah. 100%, kind of along that metabolic picture of things. Yeah. Controlling that.
Yeah.
Totally. Makes sense.
I have a very dear friend of mine whose wife started it not for weight loss, but she had the inflammatory skin condition. And she had tried numerous medications, numerous thing after thing after thing. Got on, I don't know if it was tirzepatide or a different agonist, but got on one of them and it's gone.
Was it psoriasis or something?
No, it wasn't psoriasis. It was like this, I don't know the name of it, but it was painful. And it was like like bumps that were like painful around like the hips and glutes.
Okay.
And something that like when she would sit down, like it was constantly causing chronic pain.
Yeah.
And nothing was able to get rid of it. And then they were like, let's try this. And that worked. It's just like, I don't want to call it like a magic drug or a magic pill, especially because number one, it doesn't exist. Also because I think too many people now think, oh, you just take it and you don't need to change anything in your life. That's not how it works. I do think it's a miracle. I think that these medications are a legitimate miracle for many, many, many people, I think myself included. But I've noticed that many people think, oh, well, so if you just take this, then you don't need to do anything else and everything is fixed. And I think what we're actually starting to see with those who are abusing these drugs, as with anyone can abuse any pharmaceutical, any medication, I think those who are abusing them are often taking too much. They're out of the prescribed dose, and then they're not strength training. They're not eating enough protein. They're not eating enough fiber. And then that's when we're seeing loss of bone, loss of muscle, all these other things. So I always hesitate to call it a magic pill or because it's not, but also because that leads people to believe, oh, you just take this and then you're good to go.
Yeah. Yeah. You always want to temper expectations, right? And those exact type of things you said, so people don't use it in that way. It's not the intended use case, right? I think in ideal situations is you can track a lot of those things as people go along those therapies. You're tracking body composition. And I think what's nice now too is that a lot of these home scales have gotten so much better at tracking. They used to be pretty garbage in terms of the accuracy of the skeletal muscle mass and the body fat percentages. But I think the accuracy is still not like a DEXA level, but it's getting closer to that, right? And so I think that could be a valuable thing to continue to track as people go forward on them. And also, too, with talking about dosing, I think that you can oftentimes, the minimal effective dose is less than what a lot of people would assume.
Yes.
Right?
Yeah.
So I think the little preloaded injectable pens start out 2.5 milligrams. But even at 1 milligram a week, there's oftentimes pretty profound changes that can take place at that level.
Yeah, you have me on 1.5. And like often I'll do it like once every 10 days. And I feel great. And my blood work has been incredible. Especially my cholesterol improvements have been another major thing that I was very concerned about. Just genetically high cholesterol. I had genetically high blood pressure. I am on losartan for my blood pressure, but the cholesterol was very concerning. My ApoB was high. And I was like, what the fuck, dude? Like I do like easily 100, usually like 200 plus minutes of low intensity cardio a week. My like overall nutrition is great. Fiber is great. Very high quality fats.
Yeah.
I was doing everything. And listen, I think statins are great when they're indicated. But if I didn't have to take one and I could take tirzepatide and get essentially the benefits of healthier cholesterol without having to take it, I was like, that's a no-brainer for me.
Right. Yeah, no, I think statins in the right patient still makes sense. I'm not anti-statin.
Yeah,
like
me either.
Are, right?
Me either,
but
yeah,
I think you have to acknowledge some of the collateral issues that can come with statins, right? And I know this is controversial in a lot of ways about this. People argue back and forth about, well, this study shows this and this study disagrees with it. So it gets pretty murky in there. But I think that overall there probably is some signal that increased metabolic issues can become a problem, worsening insulin sensitivity, just to name one thing. I think that some
joint issues is the one that I hear the most about.
So myopathies, right? So muscle pain can be a big problem. And there's certain genetic risk factors that are tied to that too. So like I have high cholesterol as well. And I know that, so I kind of did like pharmacogenomic style panels, which are panels that tell you, hey, you will respond better to drug X versus drug Y. So I had many different mutations that said I would respond very poorly to a statin drug.
Interesting.
I have a very high chance of getting some of those muscle issues with it, right? And so I'm like, well, my diet is already really dialed in, similar to yourself. I already exercise thing. I check off my zone 2 cardio pretty consistently. I know I'm doing all those things right. I'm not keto, carnivore. My saturated fat intake is reasonable. My fiber intake is good. All the above, right? But statin is going to have a high risk of, and I had a clearly scan too, and I had a clearly scan that showed I have stage 1 ASCVD, so atherosclerotic cardiovascular disease. So early on, not anything that I need to go see a cardiologist for and put stents in, nothing like that. But enough to where I'm young, I'm 43, and I'm thinking 30, 40 years down the road, I don't want to end up in the hospital with an MI.
Right.
Because, a lot of people can, if it's in the right place, and actually my early plaque was in the LAD, so it's in that left anterior descending artery. So it's the main one. That's the one they call the widowmaker, because if you block that guy off, your chances of sudden cardiac death are pretty good. So I knew I wanted to take some more aggressive interventions, and I was willing to do pharmacology, but I didn't want to do something that was going to give me some downsides to it.
Right.
And so that was kind of my thought process. Like, well, I'm doing everything right. I'm also taking ezetimibe, which is a very low risk cholesterol medication.
You had me on that as well.
Yeah. That's kind of addressing the gut's absorption of cholesterol, modifying that. It's kind of like a version of fiber, more or less, the way it's behaving and acting. So, but it wasn't enough. My ApoB levels were still in the higher risk category, not through the stratosphere, but high enough to where I was like, yeah, I should probably get this lowered, particularly since we know that getting ApoB even lower is better for plaque stabilization or regression. So even though if you're under 90, you kind of move into a low risk category, but hey, if you want to get the plaque out of there, higher chances of that, you got to get it even lower, which for me would probably be nigh impossible without some sort of drug to help with that, right? So I ended up doing Repatha for me, was the way that I got my cholesterol numbers down. It's a once every 2 week injectable, really good clinical data on it. It's just a matter of, again, the insurance companies are very resistant to paying for Repatha unless you come to them with a good argument for why. So in my case, the fact that I have a clearly scan that shows atherosclerotic heart disease, I have a very high chance of not tolerating a statin. I'm already on ezetimibe. All those things together were like, okay, fine. So stamp of approval on it. And again, that process was very frustrating and annoying. And, I've walked through other patients through that similar process and how hard it is to sometimes get these things approved, because a lot of times they'll come back and say, no, we still want you to try 2 or 3 different statin drugs and then come back to us, right? Even though all the data says that you're not going to respond well to it.
Yeah.
So that's a frustrating process. But in your case, I'm glad that what we're doing is effective. We don't have to have more of those sort of statin discussions that we can.
And listen, like, I'm all for statins and people who, number one, can tolerate them well, and especially like if it's worth it, like it's just a no brainer, right? For me, the main concern is the pains, the aches that would prevent someone from moving. I think that the downstream effects of having chronic joint pain, that's my main concern for it.
And I've seen many patients like that don't even realize it. They're like, I was in pain all the time. Like my muscles just hurt. I couldn't do anything. And sometimes they can go for years because they don't realize it's the Lipitor that they're on that's causing that. Right? And they stop and like, oh yeah, that all went away and it's much better.
And some people, they have none of that and that's great. And it can save their life. So it's very individual.
Yeah. Particularly if you've already had an event, like if you've already had a myocardial infarction, you have some, you've had stents, then I think the evidence there is much clearer that this is going to significantly reduce your risk of another event.
Yeah. That makes total sense. What do you think about, could someone get on Repatha and pay out of pocket?
So these are newer programs that have emerged that pharmaceutical companies are sponsoring, which I think is a good thing, right? They're kind of a direct to consumer option. So where you circumvent the insurance companies, you circumvent these PBMs, which are these pharmacy benefit managers. I don't know if you've heard people rail about those, how they kind of mess up everything and the pricing gets super inflated. So yes. So I think it's Amgen is the manufacturer of Repatha. So they have a program to where you just say, I'm going to pay Amgen, I think it's $240 a month, something along those lines, versus the 4 to 5x that you would pay if you tried to buy it just without insurance, kind of the standard route through your CVS or Walgreens or whatever, right? So there are better options out there. It's still expensive, right? That's still a lot of money per month, right? You think about how much you're going to spend a year
in this economy. That's not cheap.
Yeah. So again, it's an improvement, but it's still not ideal. I think we talked about comparison of healthcare systems. I think in Canada, drug pricing is way more reasonable than it is here. And a lot of times we'll have patients kind of do this multi-step process in order to get medication sent from Canada because it's so much cheaper.
Right.
But then you have to wait a long time for it to get here. It has to go through customs, and there's a lot of other hoops to jump through. So that's not a great solution either.
Yeah.
Yeah.
I always mispronounce the name, but what are your thoughts on, I call it Retatrutide. Am I saying that wrong?
Retatrutide.
Retatrutide.
Yeah.
What are your thoughts on that?
Varied. I think that I need to spend some more time looking at some of the most recent published data on it because from what I understand and briefly looking at it, that it's not as good as everyone thought it was going to be.
Oh, interesting.
And actually, the drug company that was spending all this money paying for the trials has delayed approval. So they know something's up too. They know it's not a miracle drug because they're not. If it was, they would have already submitted it to FDA for approval. So they're delaying that because the thought is that it's again, the trials are not as good as they would have wanted, as they hoped for.
Wow.
And so I'm hearing a lot of rumblings about that. But again, I need to look at that more myself and see exactly what it's showing. And then I have a lot of patients that get that stuff off gray market research chemical sites. And I'm not a fan of that because I think that they always say, well, they have their own certificate of analysis. I'm like, well, you can fake those just as easily as you can anything else, right? That doesn't mean anything. But and again, is it a placebo effect? Because some people say, this is the best thing ever. I'm on Retatrutide and I'm getting all these things. And I'm like, okay, I don't know. Certainly, like I said, the literature isn't supporting that it's that much vastly superior to what's already out there. And I think it's much safer because we know more about it. There's Peptides. So no, I'm not. And I know there's some compounding pharmacies out there that will, you can do it through more legitimate channels that way, but I'm not using it in my practice at this point now.
Got it. Okay. I don't take, anytime someone starts a new medication or whatever, and they're just like, oh, this is the best thing ever. I never take their word for it, ever. Especially because what I've seen in the fitness world is any time someone starts a new diet, within between 7 hours and 48 hours, they're like, this is the best diet ever. I'm like, really? Already? Like, like you've already come to that conclusion. Yeah. And I think people do this with new workouts, new diets, new medications, and especially when they're getting it from a gray market, from someone's basement. I'm like, you're out of your fucking mind.
Yeah.
I'm not taking your word for it, which is, again, one of the reasons why I'm blessed to have the opportunity to work with you, because it's based off of the research as a whole. And I will say, when I first started working with Marek, a lot of people didn't know that I was able to work with a doctor through Marek or another medical provider. It's been, I think, while I have many issues with our current medical system, I think Marek has been one of the best things in my life, and it's a great option for those who can afford it, who are also unhappy with the medical system.
Yeah. And that, I think that's one of the struggles I have too, is that I know how valuable this type of care and this type of approach is, but I also know how hard it is to scale it. Yeah. And how it just doesn't mesh with the kind of the behemoth that is the insurance-based system that's already out there, right? At one point in time, I tried to, there was another company I was working with, I won't mention their name, but their whole shtick was, let's try and figure out a way to work with insurance companies. And it completely failed. There was just no way to get some of these things that we do reimbursed. We didn't have the right, again, all these ICD-10 diagnoses codes that you need to have. It just, I think that stuff is so challenging, because even when I was in a conventional medical system, there was an entire building of people, and all they did was billing and coding all day, every day. So they're making sure that your notes are in the right format to send to insurance, and they're fighting with insurance companies about what they're getting reimbursed. It's just nonstop back and forth. And so I don't know. I think the conventional system is great. And a lot of people say this, and I agree with it. It's great for, hey, you have a acute trauma, you need to go take care of it.
Go to the ER.
It's
Absolutely.
the best, right? Yeah. The best for that. You've got a kid that has a ruptured appendix. Yeah, that stuff, it's built and functions well within those constraints, right? But I've never heard anyone tell me that they went to their, with a few exceptions, that they went to their primary care doctor and they really feel like they got everything addressed and everything is really, they feel like they understand everything going on. Like, it almost never happens, right? Yeah. The current system is these, and again, there are fantastic primary care providers out there that are doing things that go beyond this, but by and large, it's those 5 to 7 minute appointments.
Yes.
Because that's all you have time for. When you're in these insurance systems, you have to have enough output in order to justify a salary, right? And so I don't know the solution to that. I've thought about many things, but that's above my pay grade to figure out that problem. I'm just trying to take what we're doing and make it the best thing that we can, and just try and stay at the most advanced kind of tip of the spear type stuff when it comes to diagnostics interventions, and not get too carried away with, oh, we're just going to do the stack of 10 different peptides. We're going to put you on 30 different supplements. That's not really beneficial in the long run either.
Right.
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 So those are kind of my struggles that I go through.
I don't have I think the vast majority of primary care doctors are great people who just want to help.
Totally.
I think that the issue is the system that they're put in.
Yeah, 100%.
And I've told people when you and I meet a handful of times a year, it's like I get to sit down and ask you questions. And I never got to do that when I was in like the standard system. And it's just, I don't feel like a number. And it's just, even just feeling heard and getting to have a conversation with you is like, or if I'm just talking with one of the nurses, it's just like, it's nice to not feel rushed out.
Yeah.
So I really love and appreciate it. Are there any labs or blood markers that you think are uniquely important, but they don't get enough attention in the current medical system?
I think there's several. So I think the standard, like physical, when you go in in most healthcare systems, is pretty rote, right? It's going to be your CBC, your basic lipid panel, your basic metabolic panel, an A1C. And that's pretty much it for most people that go in. And you miss a ton there, obviously, right? Yes, you're going to pick up familial hypercholesterolemia. You're going to pick up diabetes. You're going to pick up really bad things that are farther down along the track. But yeah, there's no typical assessment of, iron is an easy one, right? It's so easy to measure iron levels, but it's not part of any standard screening. I can't tell you how many times people come in, they say, I'm so fatigued, I have no energy, and they've got like no iron. And it's like an easy fix. You just give them iron. It's like not rocket science to fix that issue, right? But it's just not tested for because it's not part of the standard screening guidelines. Unless you come in and you're severely anemic, then they'll check iron. But you can be iron deficient without being anemic and still be really tired because iron is how your oxygen or how the oxygen binds to the red blood cells and gets transported. You need adequate iron. So that's one example. I mean, there's many more, inflammatory factors. People don't typically measure those in standard labs. Certain micronutrient deficiencies. So vitamin D has been under attack because there was this big study that came out, I think it was the VITAL study, that showed there was no benefit to supplementing with vitamin D. So then a lot of professional organizations are saying, well, now maybe we shouldn't even measure this test. Why are we even measuring it? Because it's not impacting anything. But of course, there's methodological, it's a hard word to say, methodological flaws in the way that they did that study, right? Because it wasn't taking people that were vitamin D deficient. It was just kind of taking all comers and giving them a very low dose. I think it was like 800 IUs of vitamin D. There's no vitamin K2 with it, which we know is important in terms of the calcium metabolism and preventing arterial calcification. So there's a lot of flaws in those studies, but I think that put in that there in the zeitgeist that, vitamin D is worthless. And I think that's how the conventional medical system still views a lot of this world. And I hesitate to use labels because I think there's so much that gets kind of knee-jerk reactions to labels, like functional medicine. People I think have a negative view of that in a lot of ways. But so whatever you want to call it, but I think that the viewpoint tends to be, that stuff is all extraneous, unnecessary. It's not changing any outcomes, right? But again, the nuance is there about how you're studying something, things that we've talked about earlier, reviewing the literature and understanding, okay, what were they measuring? How are they measuring it? What do the outcomes really tell us? And that stuff gets lost because how many people are going to have the time to actually go into that? They're just going to take what Professional Society X puts out guidelines. Okay, those are what we're going to follow. Right. And that's how rank and file, that's how we're supposed to do it. And you mentioned sort of with me getting out of that world, that was another large part of it, was just how I was expected to always follow protocols. Yeah. If you have a condition that I think might be tied to, if I thought you might benefit from testosterone, my role was to refer you to urology or endocrinology. It was not to take it upon myself to look into more labs and ask more questions. It was to refer you out, right? So, yeah. Sorry, that was a little rambling answer there. But
is helpful. And I also feel like we could look at the vitamin D study, for example. I think it's a major problem when anytime a new study comes out, one new study, and people are like, we're changing everything based on this one study. It's like, let's look at the overwhelming preponderance of data to this point as opposed to just this one individual study. And we should recognize the study and add this to the mix and into the overall data, but don't change everything just because of this one individual study, which also clearly has many flaws in the design process. So there was recently, not going to name names, but I don't know if you saw, there was someone who was going out of their way to tell people you shouldn't have smoothies with blueberries and bananas because the bananas have a certain enzyme in it that are going to prevent the uptake of certain flavonols within the blueberries. And it's like, what the fuck are you doing?
Yeah.
And it was all based on one study.
Yeah.
It was based on one study. And
Probably an in vitro study and a lab bench that, yeah.
It was in people, but it was 8 people. Only 6 people completed the study, which is just a joke. But also, it was only measuring. It was only based on one type of polyphenol.
Mm-hmm.
It's like there are many different that they can have. Not to mention, it's like, what if I just like bananas in my And there are so many other ways to get these things within your diet. You're going to tell people that. I think the best part was this person said, "Don't have bananas. Instead, have avocado." But avocado is the exact same enzyme that the banana has. It's the one that browns the fruit as it gets oxidized. It was like, so you're telling them not to have this because it has this enzyme, and instead you're telling them to have this, which also has that same enzyme. It didn't make fucking sense. So I think way too many people, including people, because this person, I think that this person is legitimately brilliant. I think they're actually very smart. Yeah. But sometimes they get so focused on any one individual study or any one individual biomarker that they miss the whole forest for the trees. Yeah. So, let's see. Oh, okay. So I want to talk about women's cardiovascular risk.
Okay.
I feel like we often talk about men, which is, I think, typically, and correct me if I'm wrong, men often are at a higher cardiovascular risk. But I do want to talk about women cardiovascular risk. And are there any early markers or patterns that you watch for that standard primary care might miss? And is it anything different than what you might see with men?
Well, I think the classic teaching that is correct, this was really prominent when I was coming up through training and doing rotations, was the atypical presentations that women have of cardiovascular disease, right? They don't always present with the diaphoresis, the sweating, and the pain going down the left arm. It's more subtle presentations oftentimes. So bearing that in mind, that it's harder to know when a woman is having a heart attack, you should also be probably more aggressive about mitigating their risk earlier on, right? And so I think it's a lot of overlap between the same thing that we do in all patients in terms of looking more in depth about the inflammation factors, metabolic health, blood pressure, ApoB instead of LDL cholesterol, which I don't know why we still use LDL cholesterol as our primary risk metric in American guidelines, but it's there. I think other guidelines have started to adapt, but we're pretty slow with that. I think it's 20% of people can have a quote unquote normal low risk LDL, but an ApoB that's discordant and actually higher. So you're going to miss that unless you check for it, right? And for those that aren't familiar with ApoB, it's just a direct measurement of all the particles that are potentially atherogenic. So it's your LDLs, your IDLs, your VLDLs, all these different lipoproteins that can put plaque into a arterial wall. So
is there a number you'd like to see ApoB at or below?
It's context dependent, right?
Okay.
So I think that if somebody is otherwise no family history, very healthy, I think under 90 is a good starting point for ApoB, men and women. I think when there's family history and numbers are kind of borderline, I think that's where we have so many of these new diagnostic tools to help with that, right? I think calcium scores are great. They've been around since the 90s as a valid tool. Dr. Atkinson kind of pioneered those, the Atkinson scoring system of how much calcium you have and can help determine, should you be on drugs for cholesterol or not, right? But obviously, again, you miss a large part of the picture with a calcium score. It's just telling you calcified hard plaques. You don't know anything about the soft plaques, which are the ones that can actually rupture. So that's where these newer post-processing tools come into play. So CAT scans that use artificial intelligence to take all those images and say, okay, this is exactly the plaque volume you have in your arterial walls. Here's how much narrowing there is as a percentage. And then we can stage that and know with more clarity and definition of what your future risk is, right? So, and that's far more valuable than a calcium score of 0, because then I know much more in fine detail about your actual risk. And so, yeah, I've been a pretty big proponent of those for years now.
Okay.
And sometimes I've been pretty surprised about people that would seem otherwise like everything's going fine. They have a lot of plaque. And so then we say, okay, even though your ApoB is 85, we should maybe get this down closer to 70 in the 60s kind of thing.
And is that when you would look at like a Repatha or a statin?
Right.
Yeah.
Exactly.
Okay.
Yeah.
Got it. That makes sense. In terms of bone health, this is something, man, I don't know, my algorithm just knows me so well, but I've seen so many videos of older people, both men and women, falling.
Yeah.
Is there Is there anything outside of just strength training that you think, whether it's lifestyle or medical interventions, pharmaceuticals, that could be helpful for bone health? Is there anything that you recommend?
All right. So we're talking about outside of all those things you just mentioned?
Just outside of strength training.
Outside of strength training. Yes. Again, I think this is something that's come a long way. So in sort of the era for the past however many years, 30 years, of where it was very anti postmenopausal HRT, it was like kind of a four-letter word almost, right? The WHI trial 2001 sort of really put a bullet in a lot of those things. So I think a lot of women with osteopenia, which is kind of the precursor to osteoporosis, were getting put on drugs like Fosamax, which is a bisphosphonate drug. So those can be pretty poorly tolerated. They can cause a lot of reflux issues and other things. And plus, those are really just preventing further bone loss. They're not really building any bone per se. So there are newer classes of agents that are out there that are actually anabolic. So they do build bone to some degree. Again, they're more expensive, and it's the usual insurance thing to where, oh, well, did they try this other class of drugs first before we will put them on this newer class, right? So I think the anabolic agents are good, especially in women that for one reason or another can't do HRT, right? Let's say they have had recent breast cancer, and so they're just not candidates for it.
Right.
And these are some things that you could do to help in addition to strength training and everything else. Yeah. And then I think there's the obvious ones, right? I think vitamin D and K2 is a big one.
Okay.
Things everybody already knows about for the most part. I think some of the other things, like there's some interesting data around strontium, right? As another way, a trace mineral to help with that. But yeah, I'd make sure I have the basics covered. And, HRT is a big mainstay. I have a lot of postmenopausal women that I work with, and we like to see DEXA scans improving over time. Those T scores that are getting closer and closer to zero, that aren't going the other direction.
Yeah.
I like to see that.
So you're a proponent for women who don't have contraindications of HRT for bone?
Yes, absolutely.
Amazing. Because I know that's a very controversial topic. My co-coach Susan in the Inner Circle, she's been on HRT for a while now, and she said it's been life-changing. So it's and she has a big audience as well, and she's gotten a lot of hate and kickback for talking about how she's on HRT. I'm like, it's weird. I don't see dudes getting hate for saying they're on HRT, but for some reason in women, it's to be fair, I think it's hate from other women. I don't see men really hating on women for it, but I see a lot of like this vitriol in that menopausal space around women who've dared to get on HRT. I don't understand it.
Yeah, I think that mindset is shifting though, right? Because I think the even the Menopausal Society, it used to be the North American Menstrual Society. Now it's just like the Menopausal Society.
Yeah,
even they're in favor of HRT now, postmenopause. Okay. Of course, there's some caveats there.
Right,
they still kind of cite this. Oh, it's better if you have this 10-year window period from onset of menopause, and certainly it's more beneficial if you can start it earlier on. That's not to say there's zero benefits though if you start beyond 10 years. There's some thoughts about how maybe there's too many changes to the vascular endothelial layer that you're not going to really reverse that if it's more than 10 years out. So you're not going to really lower risk as much. But again, I think there still could be benefits to bone health, right? Some of these stimuli to the bone signaling pathways to help you have more bone building than bone breakdown. So the bones are always in this constant seesaw of bone breakdown and bone formation.
Right.
And you want to try and weight that seesaw a little bit more towards the formation part of things. So you're constantly building new bone and stronger bone.
That makes sense.
That's the goal. Yeah.
That makes total sense.
And hormones are very much in line with being that sort of pro-anabolic, pro-growth phase. Not just estrogen, testosterone, I think is another important one too. Occasionally we'll do things with growth hormone in more refractory cases. There's also some evidence that growth hormone can be helpful, I know these have also sort of a very negative reputation, but even some of the anabolic steroids can be beneficial for bone health in certain cases. If somebody's already on testosterone and you're doing everything else and you're still not maybe getting all the results that you want, that could be a case where you consider
Interesting.
Like that. Yeah.
Interesting. When we're looking at the longevity optimization space, what do you think is currently overhyped, and what do you think something that's legitimately underappreciated?
I think a lot of the peptides get really hyped up, and there's just not a lot of good quality clinical data on most of them. Some of them have gone through real trials and are FDA approved. I think the growth hormone peptides are very strong. I think those tend to work very well for improving lean body mass, especially reducing visceral fat.
Like tesamorelin?
Exactly. Yeah, I think those are really strong. But I think that people tend to think that, any injury I ever get, I'll just go put myself on BPC and thymosin beta and it'll fix me right up. And it's it doesn't work like that, right? Again, I kind of put it in that 5 to 10% category of,
Yeah.
you're doing your rehab, you're doing everything else right. It'll give you maybe some additional 5 to 10%.
Got it.
But so those are definitely overhyped. And what was the other part of your question?
What do you think is legitimately like effective or underappreciated?
Yeah. I think the underappreciation, probably some of the immune peptides, I think are underappreciated in ways that they can help people with chronic immune dysregulation that fail everything else. I think thymosin alpha-1 has some really interesting literature behind it.
Can you say that more slowly so that I can understand?
Sure. Thymosin alpha-1. Thymosin alpha-1.
Thymosin alpha-1.
Right. So it's a peptide that's made by your thymus gland. So we all have a thymus gland here that tends to involute by the time we hit our teenage years.
Okay.
And that's responsible for a lot of the way that our immune system matures, the way that we mature our T cells to be able to respond to pathogens and things like that. And so it has an effect of modulating our body's immune system. So not only can it respond to invaders better, but it also knows how not to over-respond to things that are supposed to be there.
Okay.
Yeah. But again, I don't want to oversell that. Like,
Yeah.
Please, if you have lupus, don't go think that thymosin alpha-1 is going to cure everything. That's not what I'm saying. But I think it's definitely underutilized and people don't appreciate some of the impacts that it can have when it comes to helping the body's immune system. And to be fair, it's also not something that we classically measure in most people, right? How are we measuring your immune function? You can do lymphocyte subtyping and get at some of these things, but it's expensive testing. A lot of times it's hard to interpret that data. So it's definitely not mainstream at all at this point. So
I hadn't heard of it at all.
Yeah. So it's something that I'm interested in because I think it's another way to help people that kind of get into these ruts of chronic inflammation, chronic autoimmune disease. How do we really get at that? Assuming we've already done the easy stuff, cut out gluten, right? That helps a lot of people, but oftentimes that's not enough. And there's other things going on that we need to sort of figure out. So
is there anything that I haven't brought up yet that you're like, hey, I really wanted to hit on this today?
I think we covered a lot of the interesting things that I've been reading up on when it comes to dementia, cognitive decline. Maybe we didn't really talk about the testing for it though.
Yeah,
right?
Let's do it. Yeah.
So I did mention the MoCA test towards the beginning about how that's kind of the standard screen, but there's newer testing modalities out there that you can do from your tablet or iPads to where
cool.
There's a couple companies that do this. BrainCheck is one of them, to where there's an assessment that's basically testing your reaction time. Are you familiar with the Stroop test?
Yeah.
Stroop test. Yep. So it's like where, the word red comes up and it's either going to be in the same color or not. And you have to distinguish between which matches, which doesn't match, congruency and discongruency, right? That's a Stroop test. That's an example of like a reaction time processing speed test. So that's what these online tests are designed to get at, because the MoCA doesn't really test your reaction time or processing speed, right? And those are the things that oftentimes decline first when it comes to that steady progression in dementia, right? And so it's a way to pick things up earlier and start doing some interventions and then serially tracking that data to see if what you're doing is improving it. So that's an interesting tool.
It also makes sense that the reaction time could be a life or death type situation.
Yeah, when you're driving.
Yeah, 100%. Yeah,
exactly. So that's an interesting tool. The other ones are, they do have some of these newer EEG devices, so measuring the electrical activity of the brain. And so you can give somebody a stimulus, like an auditory stimulus, so a steady tone, then you change the tone, you measure how fast their brain responds to that change. And that's another early warning sign of cognitive decline, is if that processing speed, electrical signal is slower and lower amplitude. And so again, those are not widely available, but I think those are some interesting potential there for having those available. Similar to other ways that we look at like body composition, like why are we not looking at cognition the same way that we do those other kind of things?
Right.
It makes sense that we should be.
100%.
And then we mentioned clearly scans earlier as kind of that AI way. A lot of things we could say about AI, but using it as a tool to process the data. You can do the same thing with MRIs as well.
Okay.
You can quantify the amount of volume loss and atrophy in the brain of certain areas like the hippocampus where we store memories. And so rather than usually most MRI reports you get will say things like, age-related non-specific changes, very vague, right? Not too helpful. They're usually not like, well, what do I do with this? But similar to the difference between a standard coronary CT angiogram and a clearly scan, you're just going to get far more in-depth and specificity around what is this person's risk, how much has they actually lost in terms of their brain volume and other areas of the brain. And so again, that can allow you to understand where they're at in their process and some potentially more aggressive, less aggressive interventions that you would try to do for that.
That's very cool.
Yeah.
Do you do any brain exercises, like whether it's chess or Sudoku or any stuff like that?
Yeah. So over the years, I've done various forms of those. I have like Brain HQ on my phone that I'll do.
Okay.
I try to keep up with that. I'm not 100% right, but I try to be.
Yeah.
I think that I think music is another great way to keep different parts of the brain stimulated. You know, I've played guitar since I was 13 years old or something, and so I'm not really any better than I was when I was 18. I'm kind of stuck in the same rut that I've been in, but yeah, I find that playing I just feel like something's going on up there that doesn't otherwise get stimulated in my brain. And and I think some of the literature out there supports that too, that people that have ongoing connection ties with musicianship tend to have better cognitive outcomes later on in life.
That makes sense to me. I mean, especially when I watch musicians, especially like when like a pianist, for example, they're doing like one tempo or something with one hand and then a different tempo with the other hand. And it's just like, what the fuck? Like it's incredible. So it's these fine motor
the independence of the hands. Yeah.
But you can see that with guitar, really with many different instruments, where it's just like these fine motor movements that are, and I don't know. For me, it's incredible. And the only instrument I ever played was trombone in third grade because I had to pick an instrument. And the guy came in and he was showing everyone the instruments, and he went, I was like, I want that one.
Yeah.
And then my dad was pissed when I was blowing that around the house. He was not happy.
Yeah.
But my mom comes from a family of musicians. And so I've always been interested in it, but it makes a lot of sense to me that anyone who's involved in playing music could have positive outcomes as a direct result of that. I'm obsessed with chess, and hopefully that's doing something similar at least.
Yeah. How good are you? Are you like are you trying to work towards Grandmaster?
Bro. Do you have the chess app, chess.com app?
No, my older son loves to play, but I'm terrible. I've tried reading a few of the books just so I can get some opening moves down, but I'm horrible. I don't.
Yeah, I'm not good at all. I mean, I feel like it's one of those things where no matter how good you get, there's always someone who can just destroy you.
Yeah.
I'm much better than when I started almost a year ago. But I'm like, in the jujitsu terms, I'm probably like a 2-stripe white belt.
Yeah.
Just not good at all. It's really bad. And I'll go on like sometimes a 4 or 5 game win streak and I'll be like, I'm really getting this thing. And then I'll go on a 10 game losing streak and I hate myself.
Yeah.
Before we finish, I want to give people an opportunity to learn more about Marek. If they'd like to work with you or another medical provider at Marek, is there anything that you can tell them? And we'll put all the links in the show notes. I am sponsored by Marek, as I've said many, many times. If you want to use my code, you can get a discount when you join. But I want to let people hear it from you as opposed to me as they always do. Like, if they want to work with you or another medical provider in Marek, like how does that work?
Yeah, so I think if they go to the standard channels, whether that be through our social media or through the website, it's pretty easy to get set up, and you can always request to work with me. I open up new appointments when patients specifically request me, so that could be an option. You know, the way that we work at Marek is we have a team of health coaches.
Yep.
That's kind of that first contact, so they're helping you get set up with the labs that you're going to get and sort of that initial interpretation of, hey, here's kind of how to start understanding your lab work. And then we do the provider exams with someone like myself and our other team. So other team members. But yeah, that's how it works. It's pretty straightforward. And I think the initial panels are really comprehensive. It gives us a really good place to start. Pretty much everyone that comes in, we've got something to work on. I mean, do I have people that come in that are like already, fitness paragons and have perfect labs? Sure. I get those occasionally. And those are fun conversations too, because we can usually still find something to tweak.
Yeah.
But by and large, we usually uncover some things that people don't realize. So,
yeah, I've spoken about it for a couple of years now. I'm obsessed with it. I love it. It's nice to know that I have a doctor who not only really cares and spends time with me, but also practices what you preach. You're very invested in, like, for example, if I came in and I was like, I'm injured or whatever, you're not going to say, well, just don't work out. I feel like a lot of people get that from their doctors. So it's just been, I feel like it's a great community that understands who I am and what my goals are and is willing to work with me on that. So we'll put, I know you don't really do social media. So,
well, I don't, I probably haven't posted anything in a couple of years. Stephen J. Campbell, MD is my Instagram.
Okay.
I still check Instagram, but yeah, if you're looking for somebody to post every week, sorry, I'm not doing that, but Yeah.
I'll put your Instagram in the show notes so people know that maybe once every 5 years you'll post.
Yeah.
But we'll put all the stuff in the show notes for Marek, and if people want to get to work with you or another medical provider on Marek, you can do that. Man, thank you so much for coming on. This has been a blessing. I appreciate you.
Well, thank you for inviting me. It's an honor. Yeah.
Of course, man. Thank you so much.
Sure.
Thank you, everyone, for listening. I hope you enjoyed the episode. If you did and you want to work with Marek, again, all the links are in the show notes with my discount code if you want to join and work with Marek, work with a health coach or a medical provider. And if you enjoyed the episode, please leave a 5-star review on iTunes or Spotify, or give it a thumbs up on YouTube. The written reviews help the most. So thank you to everyone who's done that. Have a wonderful week. I'll talk to you soon.